When I was in the cardiovascular surgery program at Baylor and Methodist training under Dr. DeBakey, there was a saying we all understood. There's so much money in heart research because nobody wants a senator to die of a heart attack. That's not cynicism. That's how priorities get set in this country. And it explains everything about my profession, because it is only when psychiatric illness and addiction walk into the home of a politician, a son, a daughter, a spouse, that anyone in Washington starts paying attention. I'm a psychiatrist in Florida. I want to tell you why I think my field is in trouble and why I don't think it has to be. Here's what people get wrong about psychiatry. They think our treatments don't work. They do. When you actually put the numbers side by side, psychiatric medications against the drugs used across general medicine, cardiology, oncology, rheumatology, the effect sizes are in the same range. We are not the weak link. We never were. And the pay is respectable. Not surgical money, but a psychiatrist in this country earns a solid living, and psychiatrists report some of the highest satisfaction with their compensation in all of medicine. So here's the question I want you to sit with. If the outcomes are comparable and the pay is comparable, why is this specialty being hollowed out from the inside? Let me give you the numbers, because the numbers are not what people assume. Medical students are choosing psychiatry. This year alone, the specialty added 30 new programs and over 100 new residency positions. But watch what's happening underneath. Last year, 8 psychiatry residency positions went unfilled in the national match. This year, 65. We are building training capacity faster than we are attracting people to fill it. That is the first crack in the foundation, and it appeared this year. And here is the second one. Between 2011 and 2019, the number of psychiatrists billing Medicare fell 6%. In the same window, psychiatric nurse practitioners grew 162%. By 2019, nearly 1 in 3 mental health prescriber visits for Medicare patients was with a psychiatric nurse practitioner. In rural full practice authority states, it was more than half. By 2022, nurse practitioners had passed psychiatrists in Medicare psychiatric prescription volume outright. I am not attacking my nurse practitioner colleagues. They stepped into a gap we left open. Without them, access to psychiatric care in this country would have collapsed. But understand what that means. The physician is quietly being written out of psychiatric medicine, not by a decision, by default. Ask yourself why. A neurosurgeon walks into an operating room with intraoperative imaging, neuronavigation, robotics, real-time monitoring. A cardiologist has troponins, echo, cath, CT, angiography. I walk into a room with a checklist. The DSM, count 5 symptoms out of 9, present for 2 weeks. That's my diagnostic technology. That's it. And this isn't a fringe complaint. The director of the National Institute of Mental Health said it publicly before DSM-5 was even released. The manual's strength is reliability. We all use the same words the same way. Its weakness is validity. Unlike ischemic heart disease or lymphoma, our diagnoses rest on a consensus about clusters of symptoms, not on a single objective laboratory measure. We have had that admission from the top of the field for over a decade. And what changed in the clinic? Almost nothing. If there is no measurement, there is no engineering. If there is no engineering, there is no innovation. And if there is no innovation, bright, ambitious, technically minded students walk right past our door. Now look at what we're given to fix it. The National Cancer Institute, roughly $7.2 billion. The National Institute of Mental Health, roughly $2.5 billion. Cancer research gets nearly 3 times the investment. Not because cancer researchers are greedy, they're not, and they've earned every dollar, but because the country decided cancer mattered and never made that same decision about the mind. And in Florida, it's worse. My state ranks near the bottom nationally, 49th in per capita mental health funding. Fewer than 7 psychiatrists per 100,000 people. In our rural counties, fewer than 4. We are asked to treat schizophrenia, bipolar disorder, Alzheimer's, and addiction with almost nothing. I am a soldier in the field. I see disease. I treat disease. And I will tell you honestly, the algorithms I was taught do not always apply to the patient in front of me. Sometimes I have to treat empirically, adjust, and watch, because that's what gets the outcome. That gap between the manual and the patient is not a failure of the clinician. It's a failure of the science we were handed. So what do? We build the technology, objective measurement, digital phenotyping, imaging and biomarkers that predict who responds to what, Instead of guess, wait 8 weeks, guess again. Precision medicine transformed oncology. There is no law of nature saying it can't do the same for the brain. We fix the teaching. We need dynamic educators, residency professors who ignite something. Right now, we train people in an outmoded system with outmoded tools and then wonder why the best students go elsewhere. We tell students the truth. These chronic illnesses are treatable. Schizophrenia, bipolar disorder, depression, addiction, treatable. That is the most exciting sentence in medicine, and we have somehow made it sound like a consolation prize. And we stop waiting for Congress to have a personal tragedy before it funds our patients. Psychiatry does not have to be a dinosaur, but a dinosaur doesn't know it's a dinosaur. That's the whole problem. We change or we die.